Hi, and welcome to Medscape. We're so excited today to be talking to Professor Ronald Postuma. He's a professor of neurology at McGill University, and I am Dr. Indu Subramanian. I am a professor of neurology at UCLA, and I run the Center of Excellence at the West Los Angeles VA for Parkinson's disease. So welcome, Ron. We're very excited to cover some areas, especially around prodromal Parkinson's disease, touching on REM behavior disorder, which has really been something that you've been a world leader in. And then finally, touching on some very new classification systems and some of the new ways that we're thinking about a biological definition of Parkinson's disease. So thanks for agreeing to talk to me today. Perhaps maybe you could just define a little bit about prodromal Parkinson's disease.
Sure. So when we think of Parkinson's disease, we classically think of tremor, and in fact, tremor is probably the least important. It's mostly slowness, stiffness, difficulty walking, et cetera. That's Parkinson's disease. By the time you show up in a doctor's office with Parkinson's, on average, you've had the disease in your brain for somewhere between 10, 20, even more than that years. And so there's a whole period going on where the Parkinson's pathology is progressing and you have no symptoms or signs. And then after that, you actually start to develop some early symptoms and signs. And for a period, probably on average 10 to 15 years, you have subtle symptoms and signs of Parkinson's disease, but you're still not ready to be diagnosed with Parkinson's disease by a doctor. And that's what prodromal Parkinson's is.
What kind of signs and symptoms are we talking about?
They follow an order. So probably the most reliable early thing that you can get is loss of the sense of smell. So maybe 20, 25 years before, there's often very gradual loss of sense of smell, and people are completely unaware of it at least half the time. The family members will sometimes know it, but people will say, oh, I never smelled well. Another one that happens, but is very non-specific, because lots of people have this, is constipation. And if you look at people who are constipated in their 30s, they have an increased risk of developing Parkinson's. So is it a prodromal factor? Is it a risk factor? Who knows? And then there's a few other things, like people who have depression or anxiety have an increased risk of Parkinson's disease. The one that I mostly work on is called REM sleep behavior disorder. And that's really unique because it's so powerful. So normally when you or I dream, we're supposed to be paralyzed. We're not able to move when we dream. So you dream you're running and the legs don't work, or you're dreaming that you're trying to yell and the voice isn't coming out right. That's your body going, you're trying to run and something's wrong. Your legs aren't working. So that's the normal thing. But people with this condition lose the ability to be paralyzed. And so whatever they dream, they do. So if I'm speaking in a lecture like this, or if I'm dreaming about that, my wife will hear it. Or if I'm running in bed, if I'm running, I'll be making running movements in bed. So that's REM sleep behavior disorder. And it turns out that probably on the order of 80% of people or so with this condition who get it sort of in their 40s, 50s, 60s, in fact, have Parkinson's at an early stage. And they'll either get Parkinson's proper, as we classically define it, or they'll get dementia with Lewy bodies, which of course overlaps with Parkinson's almost completely in many cases, or sometimes multiple system atrophy. And really, that's about it. Everything else is rare, 1%, 2%. But really, most people get this disorder. So that's what we've been studying for a long time.
So you said 80% go on to getting Parkinson's. What did the other 20% with REM behavior disorder end up being?
Well, we don't know. I mean, of course, that's 80% assuming you survive long enough. And so when we follow over, say, 15 years, and you can see a curve that just keeps going down. And it never actually levels off. We don't know. At 20 years, 25 years, does it go to 100%? Some people think so. I don't think there's such a thing as 100% in life. But it's a large, large majority. You can get rare other conditions. So if you have a stroke in exactly the same territory that's affected by the Parkinson's, or a MS plaque in exactly the same territory that is responsible for keeping you paralyzed when you dream, sure, you can act out your dreams too. We are now recognizing these very rare antibody-mediated syndromes. So the Casper-2s and the LGI-1s and IGLON5, which is probably the most important. These are uncommon conditions, but maybe about 1% of RBD patients have that as a cause. And after that, there's a little bit of PTSD, a little bit of antidepressant induced. And I think some of those really won't get Parkinson's over time. And then, of course, there's a vast category of things that, not really REM sleep behavior disorder, or something else that sounds like it, like sleepwalking or sleep talking or snorting yourself awake with the apnea, which, of course, doesn't apply at all. So 80% of people in a lab with a diagnosis of REM sleep behavior disorder get something. like Parkinson's.
Your work has historically been following sleep studies in populations and then seeing who phenoconverts to Parkinson's disease over time. Can you tell us a little bit about that work?
Yeah, so we started this about 20 years ago. I was doing a fellowship in Toronto, and we were aware of this group in Montreal that had a bunch of REM sleep behavior disorder patients with Jacques Bonplaisir, and I called them up and I said, we need to follow these patients because it looks like, you know, a lot of them, maybe 10, 20, 30% are going to get Parkinson's. What a great opportunity to watch. We didn't know the answer was 80 at that point. So what we did originally was just try to look at everything else, these other things that I talked about. We tested their sense of smell, we checked their motor state, we did some cognitive assessments, and we just kept following them year after year after year. And, you know, as time has gone on, we've realized, okay, it's almost all of these people, in fact, that have phenoconverted to Parkinson's. And what we've been able to do is map out the changes over time. And so this whole thing I told you about olfaction first and then constipation, that actually comes partially from these studies where you can see that right when I see them, their olfactory sense is already gone, but it does seem to regress slowly. Draw the curves back, looks like it starts about 25 years before, but clearly the motor state, we start to see subtle motor abnormalities developing 5 years before, cognitive abnormalities also about 5 years before, 7 years before, maybe max, directly witnessing a person sort of gradually get Parkinson's in front of our eyes over 10 to 15 years. We're getting a picture of how this disease starts.
Very interesting. So when you have a patient like this in your office, acting out their dreams or fighting in their dreams, what would be the studies that you would order, and what do you tell them?
So the most important thing is everyone who says they act out their dreams at night doesn't have REM sleep behavior disorder. And so, like I said, sleepwalking, sleep apnea, there's a whole lot of mimics. If you know how to take a history, I'd say you're right 80 to 90% of the time. It's really very classic, you know. Usually the spouse will tell you about it. They need a bed partner. Who will tell you that they're acting out their dreams, exactly that. They don't walk, they stay in their bed most of the time unless they throw themselves out of the bed. They don't get out of the room like a sleepwalker might do because they can't, because their eyes are closed. So there's a very characteristic history, but that's generally not enough to make the diagnosis. You need to confirm it, and that's generally with the polysomnogram. So that means they sleep overnight. You don't need to see them dream. You just need to see that they're not paralyzed when they dream. So they go into the REM sleep, and you can see, for example, there's electrodes on the chin or on the arms, and you can see that their loss of tone that they're supposed to have is gone. They continue to have tone, and then you'll often see them acting out dreams or making little twitches at night as well, and that's the diagnosis. And when you're there, now you're talking to a prodromal Parkinson's patient.
Wow. Okay. So you're effectively already telling them that they have prodromal Parkinson.
In the old days, before this hit the internet and everyone started knowing about it, it would be a more difficult conversation to raise the issue. By the way, this is associated with other neurological disorders, things like Parkinson's. I think I should keep an eye on you, and that would be news to them. I must say that's almost never news to them now. When I see them, they've gone on the internet, they've looked all it over, and they come in terrified that they have Parkinson's. So it's a bit of a different conversation. And terrified maybe isn't the right emotion to be experiencing, but certainly concerned. I mean, they probably do have Parkinson's or dementia with Lewy bodies, same thing again, or multiple system atrophy, much worse. And so it really is important to keep following these people because things are going to happen, and you want to be there for them when it happens.
Are there interventions or changes in their lifestyle or any other sorts of things that you tell them to start doing at that point?
Yeah, unfortunately, not particularly. That's one of the most difficult things. I do tell people to get a lot of exercise. Exercise is certainly good for your health in general, for sure. There are some suggestions exercise could actually protect the neurons from degeneration. I don't know if that's true or not, but the suggestions are certainly very interesting. That's very obvious advice. People should lead a healthy lifestyle. I don't give them particularly interventions on diet, except for eating healthy. I don't think we have the evidence base to really say, as a physician, I am telling you, you need to eat this or eat that or do this or do that. I think we need a very high level of evidence before we start using the authority of a physician to tell people to make changes in their life that might have impact otherwise. But the most important thing is I say, I'm seeing you once a year, no matter what. You're in a research protocol now. If you want to quit, doesn't matter. Come back and see me. Because when you start saying, I'm too tired to come in, I can help you. I can give you levodopa. I can treat your constipation. I can give you an SSRI for your depression, a cholinesterase inhibitor for your cognitive impairment, et cetera. There's actually a lot you can do for Parkinson's. So it's very important to follow these people.
And are you treating their REM behavior disorder when you've identified it?
Yeah, so there's a few treatments that you can use. You don't have to. If they just noticed it and they came into you, they have no risk of injury, then that you can leave it alone. The real only consequence of REM sleep behavior disorder, as near as I can tell, except for maybe it wakes you up once in a while and you can't fall back asleep, but really it is injury. So falling out of bed, most important, hitting your bed partner is actually probably the biggest risk of injury. Throwing something across the room, shattering things. If the bed environment is safe, you don't need any medications. We sometimes use melatonin. We sometimes use clonazepam. Clonazepam certainly helps. Melatonin might help. We don't really know. But they have side effects. And so we use them with some caution, I must say.
And is the exercise also impactful for the REM behavior disorder?
It's good for your general health, but doesn't affect the actual sleep.
And you mentioned also the people who might present with REM behavior disorder who are on medicines that may influence. Are there things that you screen for meds-wise and take people off of meds?
It's basically the antidepressants. So antidepressants are motor activators. So they help you move more in general, actually, but particularly in sleep. And so quite commonly, an antidepressant will trigger REM sleep behavior disorder that was always there, but just not in its full expression. And so sometimes then withdrawing the antidepressant can reduce the REM sleep behavior disorder, assuming they don't need it. With one note of caution, REM antidepressants, SSRIs, for example, also reduce REM sleep, and there can be a period of a few days where there's a rebound. They have more REM sleep, and actually that's a little bit more dangerous during that time. And so we withdraw them if they're not needed. But of course, if a person needs an SSRI and for their bad depression and their REM sleep behavior is not a big deal, then they can continue it.
Pivoting now to this new frameworks that we're talking about, there's been a lot of new information coming out about gene testing, about imaging, but also most recently synuclein measurements and the seeding assays. And you also, I noticed, are an author on a paper that just came out in Lancet about the biological classification of Parkinson's as well.
So this is sort of a conceptual shift. So you start going, okay, so now they have Parkinson's, they have a bunch of symptoms before Parkinson's. First it's motor symptoms that are early, and then it's olfactory symptoms that are early, and you keep pushing it earlier and earlier. Maybe we need a paradigm shift completely. If we had cancer on the bone of our arm, okay, we would not say you only have cancer if your arm hurts, if you have a pathological fracture. You have cancer if you have cancer. Similarly with diabetes, we don't wait until severe urinary incontinence because you have so much sugar in your urine before we diagnose diabetes. We go and look for diabetes. A disease is not classified by its symptoms necessarily all the time. Neurology has always been sort of, we wait for a person to get symptoms, then we define a disease. So about 2018, there's a complete shift in Alzheimer's from being an amnestic syndrome of cognitive impairment that's due to Alzheimer's pathology to Alzheimer's pathology, and then let's go look for the amnestic cognitive impairment and then stage it. But you can make a diagnosis of Alzheimer's disease in a person who does not have dementia, for example. So a similar process has been happening in Parkinson's disease. And the big thing that's changed this is the presence of new diagnostic tests. The most important diagnostic tests are the synuclein assays. So Parkinson's disease and dementia with Lewy bodies and multiple system atrophy, for that matter, are what we call synucleinopathies. An abnormal protein called alpha-synuclein is deposited in your brain. We think that's what probably causes the damage, but regardless, it certainly marks a certain type of damage that is Parkinson's disease. Now we can take a bit of your CSF, we can take a bit of your skin, we can probably even take a bit of your blood and document that there is this abnormal synuclein present. So now that changes the game, doesn't it? We don't have to wait for clinical symptoms. We can say, you have synuclein in your brain. This is not normal synuclein. Maybe we need to start thinking that you may have a very early phase of Parkinson's disease. That has a lot of challenges, okay? So how many people have synuclein who are walking around who will never get Parkinson's disease? Well, maybe we need another level. Maybe we need to show that the synuclein is having some consequences, some neurodegeneration associated with it. And so one of the staging systems that we were involved in, we did exactly this. So this is the synergy staging system. That's the one I'll talk about most because I'm most familiar with it. But the idea is that we can biologically define Parkinson's on the basis of diagnosis of a synuclein deposition, okay, whether that be the CSF, whether that be in the skin, all these other varieties of ways, and then documenting that it has consequences. So neurodegeneration associated with it. That might be a DAT scan. That might be some of the other scans that we have. And with those two things, you can actually make a biological definition of Parkinson's disease. And after that point, you can say, well, does this person have clinical symptoms? That constipation that they have, is that just constipation or is that actually Parkinson's? And has it been Parkinson's all along? So it's a real shift in the way that we do this. And so the one that I was involved in, the SYNRG, is SYN, NER, and G, which is genetics, which also is sort of a, not to get too into the details, but another way of making a diagnosis of Parkinson's in people who don't have synuclein. The details are not important, but it's a conceptual shift that's important. Just like we don't wait till a person has too much urine before we diagnose diabetes, maybe we need to think about Parkinson's like that. And when we start thinking about Parkinson's like that, maybe we can start preventing Parkinson's. We don't have the drugs yet, but maybe we don't because we've been waiting for too long.
There has been some controversy in this field. For example, Alberto Espe is sort of the notion, and I'm sure you've been in these sort of discussions about, what the relevance of these assays are. We don't know how much normal synuclein is still there because two patients can be very different with different sorts of reasons that their synuclein can also be different. So does it actually say for sure that you have Parkinson's? I think is still controversial, right, in our field. Or I mean, it sounds like you're quite defined in your about this.
Controversial. So there's two aspects to it that you have to distinguish. Okay, one is, do we think excessive synuclein is damaging to the cells? That's a biological question. I personally think it is. If you are born with a gene that will give you more than the absolute normal synuclein that we all have, all it does is this gene increases your normal synuclein, you are guaranteed to get Parkinson's. That's as good evidence as I can think of that synuclein is important in the pathophysiology of Parkinson's disease. But we don't even need that, okay? It is an astonishingly good diagnostic test. And so, for example, if we take a person who has Parkinsonism and we do these synuclein assays, something like 95% of them will be positive on that assay. The ones who don't will usually have an alternate explanation, like they have a gene that is associated with Parkinson's that isn't without synuclein. If we take those who have the olfactory loss, which is that super diagnostic test, we're looking at 98% of people. When you have a diagnostic test that's that good, it starts to change the way you need to think about how you diagnose the disease. If you're walking around, you have an abnormal synuclein and you have neurodegeneration that we can document, maybe you have Parkinson's. Why do we have to wait until you have a tremor before we say you have Parkinson's? And so I really think that these diagnostic tests have changed things. For now, they have not changed my clinic. I do nothing differently in my clinic. I see people who come in with a tremor, with rigidity, when I don't do any synuclein tests because it doesn't change anything really. We don't need them clinically right now. I can give you levodopa, I can treat your symptoms, and you can be better. When we have a neuroprotective therapy that, say, targets synuclein, we have a synuclein reducing agent, we have a synuclein aggregation inhibitor, or we have a GBA inhibitor, we have any one of these other neuroprotective agents, now the stakes are different. Now we really need to know, do you have the pathology in your brain? Not just do you have tremor, but do you have a pathology that I'm going to give you this drug, which is going to cost $20,000 a year, requires an IV infusion once a month for the rest of your life? I better make sure you actually have the underlying pathology, that we're not wasting everybody's time here and everybody's money. So I think that's really where things are going to change. And these diagnostic tests are going to start changing clinical practice when we have disease-modifying neuroprotective therapies.
One last question. The REM behavior patients that we're following sort of forward, where would you think, or is there at all a sense that these sort of tests would be useful in that population?
You almost don't need them to make a diagnosis because it's that high. So let's take their REM sleep behavior disorder and let's add olfactory loss. Okay, you put those two things together, you're in the 95% territory already. Throw in a little bit of motor abnormalities, throw in some constipation, we're looking 98, 99% certainty. So I actually don't need those tests in my practice even now. Will they be useful? Well, it's going to be useful maybe in the future when we have, again, it's the same conversation as Parkinson's. Why do we have this artificial boundary between a REM sleep behavior disorder patient and a full Parkinson's patient? That's a completely artificial boundary. These people have synuclein in their brain. They have neurodegeneration that causes their REM sleep behavior disorder. Whether they have a tremor now or whether they're demented now doesn't really change the fact that I'd really like to do something about this. The earlier, the better. And so when neuroprotective therapy becomes available, yeah, I think I'm going to get that skin biopsy and I'm going to make sure it's really synucleinopathy before I commit them to a lifetime of their therapy.
Well, this has been a great discussion. We look forward to hopefully neuroprotective therapies that we can apply to these patients, given all of this new ways to detect people early and earlier.
Absolutely. Thanks very much.
Thank you.